So today I'm going to talk to you about the Medpor technique for ear reconstruction and try to give you an understanding of what's involved. First, I'm going to introduce you to my family. They are all here in the back row. My husband, John, my son, Jeffrey, who's 12, my daughter, Casey, is 11, and then those are our two pups, our little Basset Hound and our Great Dane puppy. This was taken 6 months ago, so that guy outweighs me and has 5 times that size now. So I often get asked this question, what made you decide to devote your career to making ears? And it was not planned. And so the answer that I typically give is, it was really serendipity for me. When I saw the definition, it really kind of is what led me to where I am today. So it's the effect by which one accidentally stumbles upon something truly wonderful, especially while looking for something entirely unrelated. So what that means is these 4 slides are kind of my pathway to getting to making ears. So that first slide is a Rodin sculpture representing that when I was a kid and even growing up, I loved art and design, and I knew in my career somewhere that I wanted to have creativity be the central focus. What I didn't know, even though I was the daughter of a nurse mother and an architect father, I was not interested in either architecture or medicine. So I just went to Berkeley and thought I'd take a liberal education, and I discovered this, which is Frank Lloyd Wright's probably most famous American House, Falling Water, and fell in love with architecture. So I studied architecture and planned to be an architect, and I got my degree in that. And it wasn't until after completing architecture, I started thinking that, this may not be enough. It was actually my husband's fault that I ended up in medicine, because he encouraged me to go back, take pre-med requirements, and enter medical school. So I went to Stanford for my med school and discovered I missed the creativity. And so when I saw a little baby with a cleft, I realized this is incredible, because it's sort of like sculpting on a patient, albeit. And then when I saw my first ear reconstruction, I was like sold. I came home, told my husband, I figured out what I want to do. So before we can go into how to make an ear, there's a little bit I'd like to teach you about the anatomy of the ear, because I think it's important when you're trying to figure out what you want to do. So there's 5 structures that are needed, I believe, to make an ear look like an ear. There's the helical rim, which is this delicate, thin, curved part that needs to cast a shadow. The antihelix forms the center of the ear. It's like a curved Y shape, and it's one that all of us focus on when we're making ears. The conchal bowl is where we put our earbuds or earphones, so it needs to be deep, and it needs to cast a shadow to look realistic. The tragus is this little cartilage piece that sits right in front of your canal, and whether you have a canal or don't have a canal, this little element is really important, actually fairly hard to make from my standpoint, but it's what makes an ear look realistic. And lastly, an earlobe is critical, not just if you're a girl and need earrings, but also just to make the ear look realistic. So these are those 5 structures sort of all represented. And it's important to know that all of these would be considered so-called normal ears, but ears are not the same. Much like our eyes and our noses, they have character and personality, and if you have only one ear, you have to focus on making the opposite ear match the one you have. And similarly, all our Microtia ear patients' ears are not the same either. And so from my standpoint, and I imagine from most Microtia surgeon standpoints, we really individualize and customize how the ear looks, and it goes with each patient. So we're going to talk briefly about a grading system, just because we as surgeons use this system, and you and parents often wonder, what grade is my child's ear Microtia? So it's a severity grade, grade 1 being least severe, grade 4 being most, and the first grade just has a small but almost normally formed ear. Grade 2 has some recognizable anatomy. It's not always the same, but it's usually the bottom half of the ear looks pretty normal, and then the top half doesn't. Grade 3 is the most common. The overwhelming majority of patients have a grade 3 Microtia, where you have a little earlobe remnant and a little cartilage nubbin above it. And then grade 4, you have no canal and no ear. So I'm going to very briefly touch on some facts on microtia, but your talk tomorrow from the geneticist is going to go into much more detail about this. But this is a patient of mine. They live in Ecuador, and she's, Maria Amelia's 3 years old, and she's pictured here about, well, I guess she's 4 now. She's about a year out from surgery, and she's snuggling with her grandfather, Guillermo. And so in their family, there is a genetic component to the microtia. But truthfully, it's really only about 5%. So most of the time, we don't know what causes the microtia. There are some few things that are environmental that can contribute to it, but almost every mother of a newborn baby with microtia says to themselves, what did I do? What is wrong? Did I do something in pregnancy? No, the answer is strictly no. We do not believe there's anything, it just happens. So, okay, I need to tell you, this little guy is Tiffany Wilkie's son when he was 9 months old, and with bilateral microtia. And microtia, the word in Latin, means little ear, as much of us know. There's a range in different locations to how common it is, ranging from 1 in 2,500 to 1 in 12,000. We see boys more commonly than girls have microtia, and the right side's more involved than the left. And for bilateral patients in the literature, it's between 7 and 22% that we see. And then over 90% of these kids have a conductive hearing loss. And our next speakers later this morning will be talking about that. So microtia also can be associated with syndrome. So here, this is Tyler. Many of you might have met him running around yesterday. And Lauren's also going to be here today. So Tyler has Treacher-Collins, Hemifacial Microsomia, also very common, and little Lauren has Goldenhar syndrome, or OIV. Again, more details tomorrow. But I guess the point is, particularly when you have a child with a syndrome, is that we need a team. You know what? There's a lot of issues. It's not just missing an ear and unable to hear. And so when you have other issues, this team of 10 specialists are critical, and they all have a role, and we have 10 speakers, and they cover most all of these bases, and they're going to tell you what their roles are. So I truly believe that the surgical creation of microtia reconstruction is an art. And here's an example of 2 different sculptures of ears, and you can see they're different materials and a different feel, but they both represent ears just in a different way. And it's not terribly dissimilar to your options in ear reconstruction. There are pros and cons to both of these techniques, the Medpor technique and the rib cartilage technique. And we want to teach you both of those, the pros and cons. So when I look at what are my goals for my patients' microtia reconstructions, I came up with a list of things that are important to me that I can do for my patients. And first and foremost, you want a natural and realistic looking ear. You want it to look like the opposite ear if they're only involving one side. You would like it to be, if possible, in a single outpatient surgery at an early age, as easy on a child as possible. So there's no perfect surgery, but I did do both the Medpor technique and the cartilage technique. And in my hands only, and I always talk about in my hands, for me, the Medpor technique allows me to achieve these goals. So in, I think, 2010, I stopped offering cartilage surgeons, and if you want a cartilage reconstruction, refer to wonderful cartilage surgeons for that. So we're going to cover today Medpor. So what is this material? The name of it is porous polyethylene. It turns out that when the FDA tested all the things that can be put in a human body, polyethylene was the least reactive of everything. So the reason why it's least reactive is the brilliance of them creating something that's porous, that has these little pores or holes. So it makes the material extremely lightweight. It's 50% air, so it's not heavy at all. It is rigid, but it's not heavy, but it's incredibly strong, so you can create something very, very thin and delicate and still have strength to it. So to me, that's been a critically important part to getting the results I'm hoping for. But the other thing that's so brilliant was they made these holes just the exact size to encourage your body's tissue to integrate into the implant. And that's what makes this work. There's a very long track record of using this in the body. The porous form for over 30 years, the non-porous form for many years before that. Over 400,000 surgeries have been done with this, and you can see from what's there, we use it all over the craniofacial anatomy. So this is my goal today. I'm going to give you the who, what, where, when, why, and how, most of those except for the where, today. So we'll go through that, starting with how we do this. So this is a little girl who's 4 years old with a grade 3 microtia and atresia. And we spent a fair bit of time actually in the planning portion. That's the beginning of the surgery. And what we most commonly get asked is if she's only 3 or 4 or 5 years old, and we know this ear is going to grow, her right ear is going to grow. Obviously, when she becomes an adult, it's going to be bigger than it is today. How do you know what size to make the ear? And the truth is, we really know exactly what size, not exactly, but we know from many, many studies by anthropologists over many years. Turns out there's a lot of people interested in studying the ear and how it grows over time. And so what we've learned is that at 3 years of age, your ear is already 80% as big as it's going to ever be. And then by 7 years, you're even a little bit over 90%. And so that helps us gauge. The ear is almost as wide as it'll ever be when you're a little newborn, to be honest. It's very wide, and it grows taller. And so we adjust the Medpor framework to compensate for that. So the first thing we need to do is trace the ear that she has on that right side. And then with what we know, for little girls, I draw mom's ear, and for little boys, I draw dad's ear, and then we can figure out what the adult size is going to be. And then we use a template under anesthesia when they're asleep to draw that anatomy and figure out how to move it to the opposite side. The next thing we do in surgery is the implant. I actually do that usually before the patient enters the room because I've done my first drawing in the pre-op. And so this implant really hasn't changed much for 18 years. This is similar to it's basically the second iteration of the implant. And they all start out this way. But as we discussed earlier, we need to customize these ears. And so we do extensive work to change the ear, to make the Medpor delicate, to make it match the anatomy of the other side. And then when we're done with all the soldering of putting these two pieces together, which we melt, and we add a bunch of Medpor to it, this is what we get. And now I'd like to show you a video of how we can size this implant. Patient's ear, and then our Medpor implant consists of the rim and the base that have been modified extensively. And just to demonstrate how we can change the size of the patient's ear, if the patient has a very large ear we're trying to recreate, we can make the rim very large, or we can solder it together in such a way that the ear can be very small. So it's completely customized. And then these two pieces fit together, and after they're soldered, they become one single piece. So the next slide shows you what the completed implant looks like. So here's the completed implant with our new design, in which case we actually connect the helical rim to the base at almost all areas, with only one area left open for shadowing of what's called the triangular fossa. And you can see there's a lot of detail in the carving of the implant to show hopefully a lot of detail to the ear and become more realistic appearing after surgery is completed. So one of the things I really like about Medpor that helps me for symmetry is it's completely three-dimensional, and I get to control how three-dimensional it is. So the way we can tell, some children have an ear that sticks out a little more and some a little less. So we can actually customize how much it sticks out by adjusting the base, the very bottom part there. And it helps me get an angle and projection. So the next is the planning of the surgery right at the beginning. And so you'll see there's an incision, and that's here. It's located behind the ear. And that incision is used to get what we call the flap. I'm going to talk a lot about the flap because to me, this whole operation has to do with that flap. So what's a flap? I'm going to show you the area that the flap encompasses, which is underneath the scalp, above the ear, and it's obviously deep to your skin and your fat and your hair follicles, but it's on top of everything else, on top of the bone and the muscle there. And it's supplied by arteries, but in addition to arteries, it turns out it's supplied by nerves. So I didn't exactly understand that until I had enough adult patients to teach me that when you touch them after surgery here, their brain thinks that you're touching them on their head, and it gives them a strange sensation. It doesn't happen to the kids at all, but the adults taught me that actually even a couple weeks after the surgery, you can start to feel sensation. And then many months down the road, you get more sensation. So this flap is used to cover the entire implant. It has to be covered 100%. You will have problems if it's not covering 100%. And so once the flap is in place, we have to cover it with skin. That seems pretty obvious. So it's critical what skin you use and how you use it. And it has to do with the color, because it has to match the opposite ear. It has to at least be ear colored. So you can see that there's good skin sitting behind the microtia remnant and even some in front. And we use all that, quote, ear skin that has no hair but is the perfect color. And that covers the front of the ear. And this is true for, I'd say, probably all microtia reconstructions. But the back of the ear I treat a little differently. For girls, I prefer to use the abdomen because it's got a really great scar, tends to heal very well. It's hidden from view in terms of where the skin comes from. However, there is a little downside to the tummy, which is it's a little more brown, and so you don't have as good a color match. But on a girl whose hair is often behind their ear, you don't see the back of the ear as much. Boys, the back of the ear is visible. And the best color match on the body for a man is actually the upper inner arm. And that also turns out to be the spot on a male that has the least hair. Almost everybody's got a pretty bare area right here. And so I don't like using the tummy for the color match and the fact that you will, in puberty, have the risk of getting hair growth because many men have hair all over their tummies. So that's my philosophy on that. So to this point in the surgery, we've gotten pieces. We've gotten our implant, we've gotten our flap, we've gotten our skin grafts. And we just have a bunch of pieces. And it's the next half of the surgery, which is basically the second half, what I call where all the magic happens. It's very much my belief that this is the artwork, and this is where having that visual eye comes into play for me, because there are 100 or more than 100 tiny little finesse decisions that have to be made on all these steps. How the implant sits, how do you cover it, how do you get the flap where you want, how do you put the skin where you want. All these little things coming together is what helps me get where I want to be at the end of the case. And this is not easy to time. Sometimes it takes longer, sometimes it takes less. But I kind of think of it as an analogy of you can have pieces. So here you see all different types of wood and sheep intestine. And in and of themselves, they don't really impress us. But when you have an artist turn this into an amazing musical instrument that functions and is incredibly beautiful to look at, that's sort of the goal, is that you take those pieces and then you create or craft an ear from it. So I'm going to tell you that there's a little warning here. The next two slides show this flap in actuality. The first one shows a video of the suctioning down of the flap, so you can go from just a pink cover to an ear, and the next one shows the ear. So if you are squeamish, close your eyes now and I'll tell you when to open them. So this is a video. You can see that ear is going to have suction pressing on it. Oh, whoops. Did it go? There we go. This is the suction, and then you can see it becomes an ear right there. And that suctioning is also a critical part to getting detail. And this is what that ear looks like before it's ready for skin to come on. It's pink, it's not bloody. You can open your eyes if you were not looking. And this is what the ear looks like at the end of the case for the little girl you saw the pictures of before. So the earlobe and the tragus are made from the tissue that was there, but these are the skin grafts, and you can see they're sewn on, and they don't have any color because they haven't yet, they're not alive yet, they were just a graft. Now I'd like to show you 3 months of healing. You need to be patient with these things. They take a long time to heal. And the first week, they look atrocious because they are purple and red and swollen and scabbed. And that's all perfectly normal and what we expect and want to see. And the purple comes from the fact that blood vessels are growing into these grafts, so they've changed color. And then over the next months of time, you can see that the skin grafts start to normalize. You start to get a little improvement in color. Very slowly, you start to see this swelling come down. But really, it's probably about 2 months before the ear even starts to look much like an ear. You can see we pierce ears. And then as we get more towards 3 months, these grafts are changing and the color's improving. And finally, at 3 months, you're not done healing, but that's where you get to. So here's this little girl 3 months after surgery. She only ever required one operation. In the last few years, there's been some nice advances. They used to, when I learned this, shave half the head, and that was not good for a lot of patients. So we just save half an inch now around the ear. We do not use drains after surgery anymore. They used to be around for a week or so, but we remove them at the end of the case when the child's asleep under anesthesia, and you don't have to deal with it. This is my team, my Microtia team from Canby Surgical Center, who are a tremendous support for our patients, and they give our kids so much TLC. During the case, one of our nurses, whoever's in the case, will make a customized dressing for these kids. So we ask them in the morning, what do you want? And whatever they come up with, we make for them. So I think the kiddos like that. And then post-op, the kids go home after about an hour of being in the recovery room. There's only 2 dressing changes in the first 2 weeks, at 1 and 2 weeks, and then parents don't have to do anything for the first 3 weeks. That's the ear's healing. And then everybody wants to know, when can I get back to stuff like that I really enjoy? And it's 6 weeks before you get back to all your sports and all activities. So the next is the why I do it, why I've chosen this technique to specialize in. And first and foremost, I feel like in my hands, it allows me to create a very realistic and symmetric ear. This is an ultra close-up view of an ear. So hopefully, you can see what the real result is. There are some scars, but basically it allows me to give an ear that looks similar to the other side. And then for bilateral patients, you can make hopefully 2 ears that also look very symmetric because you're using an implant that you completely control. You're not subject to any limitations from that. So this is David, and he'll be on the patient panel tomorrow. And we did 2 surgeries for him. You'll see this video that shows him 5 months after his first ear combined with a bone-anchored implant, and then about 2 months after the other side. So I think in just 2 surgeries and not very long after those surgeries, he's walking around and able to wear his hair short and not be self-conscious. For me, I think hemifacial kids provide an extra challenge because they're missing soft tissue and bony support. And so the Medpor, that part I told you can control projection, really helps me create in kids with this deficiency an ear that I hope will look somewhat symmetric after it's been done. So here she is after 1 operation. And I like the fact that we can make an ear that hopefully looks like an ear in just 1 outpatient surgery. So I looked back at my last 2 years of kids and tried to cull for some data, and it turns out in my practice now, about 75% of patients have 1 operation and 25% get a little touch-up revisional surgery. Here's this little girl who's after her operation. So when should we do this? This is a picture of one of my youngest patients, a little 3-year-old there, and one of my oldest patients, who's 49. And both of them had a single operation, and this is how they look after their 1 surgery. And there is no right age, and it's completely up to a family when is the appropriate time. So I don't tell you when the right age is. But I do make one point that I came upon after doing many, many of these surgeries. And this sort of illustrates the difference between those of you sitting there and the way I see me. You guys spend 100% of your time with your 1 child with Microtia and Atresia. I spend a tiny fraction of time, just a little snippet, but with hundreds of children with Microtia. And if you ask my patients, I keep in touch with them for many, many, many years after surgery. And so what that has allowed me to do is listen to these families and learn from them. And they tell me that all these kids, regardless of age, seem to have a boost. I think most of us would agree, have a boost after getting surgery. But what surprised me and I didn't really appreciate is even these little tiny people, the 3 to 5-year-old kiddos, have a change in their confidence. And I have kids and I'm a mom, and I figured, you know what, they don't care. They run around, it doesn't even affect them. Okay, but then I met this little guy. This is Trey, who is 3, and here he is with his anesthesiologist, and they're getting ready for surgery. And if you look at Trey, you can see he's got a little left ear, and his little comfort bear has a little tattered left ear. I thought, oh, kids gnaw and stuff. There's no reason for why he would choose an ear and a left ear. He's 3. It's not possible. And his mom's like, no, Dr. Lewin, this is intentional. And she saw the skepticism in my face, and she's like, okay, you know what? I'm just going to email you a little photograph. And she sent me this. And I couldn't believe that it was 3 of the exact same bears, and they all have a tattered left ear. It just shows you I firmly believe there is a lot more going on in all of our kids' brains than what we see on the outside, and we should respect that about our kids. So it's not critical, but I found it interesting that after he got his big ear, and he had 2 ears that looked fairly similar, well, he chewed the other ears, so then all the bears' ears were the same. And so he has 3 bears with 2 chewed ears, and then he had his second surgery and he was done. And then she sent me this one, which has those 3 bears with the tattered, and then here's the newest bear, and his ears are perfect. So it's a little anecdotal story, but it kind of blew me away. So because of hearing these patients' stories, and it's not just him, it's other little cute things, like when my little kid went to preschool right after he came back from his surgery and he was only 3, he walked into the room ear first, because he wanted everybody to see his new little ear. So if you ask me, given my druthers, if it doesn't hurt and you have the opportunity, I think it's nice to do this before kindergarten. I don't think it's critical, but I think it's kind of a nice thing to do. So this is Davin. He's a little guy, bilateral MA patient, and here he is before kindergarten, and he shows up to class at the beginning, and he's got 2 ears, and then it's a non-factor, and he goes to the last day. I just like that picture, it's very cute. So I do think getting these kids before other kids are teasing them is probably a good thing. And I also feel the one thing people don't often talk about is there is less anxiety to a 3-year-old going into surgery or a 5-year-old going into surgery than an 8 or a 10-year-old, because they're trustworthy, and if you're honest, they get it. So who's a good candidate? Well, in addition to children, I like Medpor a lot for adult reconstruction, and you can do in 1 or 2 surgeries. And I really like it for bilateral patients. This is Sarah, who's here today, and you guys are going to actually hear her talk tomorrow. But here in this photograph, she had only had 2 surgeries. She can wear her glasses. She has 2 ears. It was not so many surgeries to get to this point. Patients with a low hairline present a difficult challenge, because if you look at that picture, this area is where the ear belongs, completely within hair-bearing skin. So we have to throw that away. It doesn't lend itself to all techniques, but for Medpor, we don't care at all. We can put the ear where it needs to go. Similarly, we can help at the time of Medpor to raise a low-set ear. So she's a little tiny kid, so her ear's bigger on this side than this side, and we didn't quite get her up as high as, to be perfectly symmetric, but from where she started, I think we made an improvement. And then there are patients out there with failed reconstructions that are looking for a solution, and Medpor is a great solution, because even after attempting another ear reconstruction that didn't go well, we can help. So this is one of our Iracles patients. She got 2 free surgeries through Iracles, and she got transportation through Ear Community, so we really appreciate that everybody in this community kind of rallies together to help these kids. But what blew me away is this ear, 17 surgeries. 17. So all the scar tissue and all the psychological trauma, this kiddo was depressed, and I got a desperate email from her mom. And she was the inspiration for Iracles. I got the email before I started the nonprofit, and she was the first kid I called 2 years later when our nonprofit went through. So here she is after those 2 surgeries, and she's happy, and Mom tells me she stares in the mirror all the time looking at her ear. So burn injuries are challenging. This was maybe one of my hardest cases. This gentleman had burned scalp and everywhere. 51 years old when he had this done, but we were able to get him an ear. This is a traumatic amputation of a young lady that we were also able to help. So that's the basics on that. So this is important. We're going to talk about the real scoop, because my feeling is that there's a lot out there that people don't understand if they're not doing this surgery every day. So I like this slide. The quote is, "The problem with quotes on the internet is that it's hard to verify their authenticity. Abraham Lincoln." There is so much out there on the internet that is not accurate. And I want to kind of dispel those myths and give you the myth and the fact. So this is the biggest one I hear, extremely common. All these Medpor ears get rejected. The body's just going to reject it. So I got to set people straight on what that means, because the truth is, a kidney transplant can be rejected because your body fights it, because it recognizes it as not your part of your own body. But something that's not alive cannot be rejected. It just doesn't happen. So no implants get rejected. That's not to say they don't have problems. So what I try to describe is the Medpor, the reason why it does work is that it integrates the tissue, as we talked about before. But when I think people talk about this rejection, it's not an implant problem at all. It's this thing I've been telling you that's so critical, the flap. It's a flap problem. It's in the surgical dissection of that flap. And my feeling is, if you do that flap perfectly, you're not going to have complications on your ear. And converse is true, if you do not do it perfectly, you're going to have it. So it's one of the difficult parts of Medpor is there's no real generous room for error, but as long as you do everything properly, you're going to have a good ear. So before kindergarten, children are just too uncooperative to have surgery and follow post-op care. This is on many websites. But they're not on websites of people that have ever done this on really young children, because only one technique allows you to do it on this. So I just tell you, it's just not true, and we have a ton of patients you can talk to and ask them. Not that everything's a breeze. Everybody has their ups and downs and soreness after surgery, but these kids are awesome. You just have to give them a little love and a little bribery, and candy goes a very long way, so I break all those rules about video games and candy. Where are my kids? You guys haven't had surgery, so you don't get that. So the Medpor ear is very sensitive to trauma. I wouldn't say it's to trauma, because these ears get bumped and bruised and scratched and they bleed. And again, when that flap works, there's no issue. But what they are sensitive to is, because the tissue's moved from up here to down here, they're slow to, not slow to react, but they're slow to relieve swelling. So this is a kid, 2 texts I got in the last very short while, last month. This little guy bumped his ear on the slide at the park, and parents texted me like, "Oh my God, Dr. Lewin, something terrible happened." And no, it's just swollen, it reacts, and it goes down after a couple days. And then most summers, I get, like this summer we posted about it because we had 1 week where 4 patients sent me mosquito bites. And it does react impressively, and it freaks everybody out because it's super swollen. No antibiotics, no treatment, just wait. It'll figure it out. So the temporoparietal fascial flap that sits on top of the implant actually is mobile over the implant. So you can see that the skin moves all over, even though the implant stays the same. And similarly, the ear can move and come off the head or move back. Quite mobile, because it's not fixed to the scalp, and it doesn't hurt. Right, Brennan? So this little guy's coming, they're a local patient, and I think they're coming tomorrow. So the point is that the flap, this magical flap, has 2 layers. It's called bilaminar, and one sticks to the implant, one sticks to the skin, and they move against each other. That's what I was trying to demonstrate, and that's what equals durability. This girl is similarly a lesson in durability. So her first surgery was done 17 years ago by another surgeon who did a very nice job getting this flap and these grafts and reconstruction. And then she came to me 5 years ago because she needed a revision, and that was a very old implant, and we decided to do a newer style, the new implant. And so we replaced it, And you know what? We used the exact same flap and grafts. We added no extra skin or tissue. You simply unfold what was there, take out the implant, put in the new, and put it back. And we were able to adjust her ear to get better symmetry and I think a very nice reconstruction. So that shows the durability as well. People will say, somebody at the meet and greet said this to me, I hear Medpor only comes in one size and it can't grow, so it's not going to match. We sort of went over that, but I'm just going to show you that we make it the adult size as we said, but here's kind of a little kid that can prove that. So here she is at 3 and at 6. And if we flip her image of her normal-sided ear and we add guidelines to prove that we are all at the same size, you can see that there's a difference between her ear, not her Medpor ear, but her other ear. So that in the top, when she's 3, it's about 80% of the size of the ear, and at the bottom, it's probably closer to 90% of the ear, but it's still got some growing to do, as does she. This is also on a lot of websites. Large scars in the scalp lead to baldness, and indeed, this was true. 10 years ago, when I learned this technique, this was the incision used to get that flap out. And I recognized pretty quickly, as soon as I got into practice, this was the worst part of this technique, and a lot of complaints about it. And the boys hated this, and do they tattoo, or they're just hard to get rid of these scars. So I started trying to think, how can we do this without a scar? And using some technical equipment, came up with a technique to harvest this flap without any scars. And it took me a couple years, but this is Giovanni, this little guy. He's, oh my gosh, he's much older now, but he's the first patient that ever had this technique, and I did him in 2006, and I have not needed a scalp scar since then. So we do have to talk about risks. It's a really important part, and you guys need to feel very comfortable that you know what the risks are. The key, since everything has risk, is your surgeon has to know how to deal with that risk. So I looked at data from recent because I noticed that I believed, well, I wasn't sure, that my complication rate was going down over time. So I took every single ear in an 18-month time period, so the last 18 months, from January 2013 to June 30, 2014. And there were 83 consecutive first-stage ears. Didn't include any of the other surgeries that I do during the year. And these are the significant risks, meaning they require a surgery. So the biggest one that I always talk to patients about is if you get a hole, and we call that an exposure. And in that time period, I had 2 patients, and it was a 2.4% rate. This was lower than I expected because several years ago when I looked, it was double that. And I attribute that to the second half, the art part of the surgery, getting that flap to sit just perfectly on top of the ear, because as I've said over and over, the flap is the key. I had one little girl who had bleeding kind of right in front of our eyes under the skin graft, and we had to remove that little, about 1 milliliter of blood so that we knew the skin graft would sit down, and she did fine. In this time period, I've had no fractures. I really did have fractures in 2010 and 11, right around there, and after we made this implant change, I believe that's why we're here. It doesn't mean there's zero risk over one's lifetime, but at least in this short time period, we haven't had any of those kids have a fracture. Touch wood, I've never injured the flap artery in my career, so I'm hoping that stays at 0, and there were no failures in this time period. I usually tell parents 1 or 2 kids a year have a failure. We've just been really fortunate. These are the 2 exposures I had last year. So you can see that the Medpor is exposed here, and in this kid, the Medpor is exposed here, and it's frustrating because they have to come back to LA and have a surgery. This is a little guy from 4 or 5 years ago who developed a fracture right here. You can see the rim is no longer smooth, and I did that same, lift up the flap and skin, no extra grafts, and we just replace it with a new one, and he's in Singapore and doing great and really active athlete and has not had any fractures. So then in the same group of kids that we studied, I looked at non-surgical treatment, and we had 2 infections in that time, and they both resolved with medication, with taking antibiotics. But it is the reason I make you guys stay in LA for 2 weeks. You need 24/7 access to me during that period, because if anything is amiss, you need to come see me right away, and we'll start you on antibiotics. And the truth is, as long as you treat, you will be okay. But if you have a delay, that's where you will have problems. I have 3 kids that had a nerve injury. It's not the facial paralysis, but it's the nerve that powers the eyebrow. And that's a risk very specific just to the Medpor technique. And it relates to the anatomy of the artery I need and where the nerve is. And I can usually tell the risky kids in the OR when I figure out where their artery is, and I kind of warn parents, but 3 of those kids did have that. It doesn't necessarily mean it's permanent, but it's injured. And then keloid is a very thick scar. I've had those in the past, several years ago, and there is a treatment, but I haven't had any in this time period. So this is a scary slide, but you know what? We're here to tell you the risks, and this is a scary risk because this is an infected ear. This is 2 weeks after surgery. We didn't see it at 1 week. This kid is why I make you stay for 2 weeks. But we treated her, and we were aggressive with it, and this is how she looked with no surgical intervention, but antibiotics only. So there clearly are disadvantages to all these techniques, and Medpor is no different. We don't have the same length of history of time with this technique, so we know only out to 23 years, first one being done in 1991, and beyond that we're not sure. We believe from other surgeries, not ear surgeries, that it lasts a lifetime, but we don't know. My biggest frustration, this just scares me and I'm annoyed by it, but if you get a hole, you have to come back for surgery. And I'll tell you that every day I do this, I still find this a challenging operation. I have done hundreds of these, and I think I still learn every time. The latest advances, soft tissue sculpture, I don't know what else to call it, but it's that art part in the second half where I'm playing more with techniques of how to move your skin around, like a little mini facelift helps and a neck lift helps, and really creating this transition between the earlobe and the implant. I've been working on that and the tragus a lot lately, and I think we're getting closer. We're not there. I've done some new things with bilateral patients to improve color and and have the front of the ear look ear colored, which formerly we didn't have enough skin to do that. I've been doing a lot of these combined first stage Medpor with the bone anchored implants because we can do it without a scar, even whether it's the magnet or the post, we can do both of them without a scar, which is nice. And then custom tissue expander, which you have to be a local patient, so it really isn't good for all patients because I make you see me every week. But we take this water balloon and we slowly blow it up over a couple months to create as much skin as we need to cover the whole ear and not have to go anywhere else. So it looks crazy on the patient before surgery, but in the OR, you can just use one piece of skin and it does everything I want it to do. So now I'm quickly gonna just show you a few results. These are recent results, none of them on the website yet, but I think give you a little taste. So for unilateral microtia, here's a 3-year-old little guy. He only required 1 surgery. And here he is from 3/4 view, before and after. And this is that little girl who was with her grandfather from Ecuador. And here she is before and after. And it's nice for an international patient. She doesn't need any more surgery. You only have to come once. This little girl had 2 surgeries. She was required a little touch-up after her first surgery. You may have seen her because we use these pictures for our LAMAC brochure. This little girl had a canal by Dr. Kesser, and she is before and after her surgery. She had 2 surgeries. We did do a little revision. And Courtney's here. Is Courtney here? Courtney's there. So I saw her at the meet and greet. Courtney's just celebrated her 1-year ear anniversary. So she was 1 month out from surgery when she was here last year, and she'll also be on the panel, and here she is before and after. She already had her ear pierced, so we didn't have to do that. And then real quickly, kiddos with bilateral. This little guy is an irical patient, so we don't fly them here, but once they're here, we can give them, in his case, he got 2 free ears and 2 free bone anchored implants, and he's done. He won't need any other surgeries. There's another kiddo, also had 2 surgeries so far. He's only, I think, about 2 weeks out on that left ear over here, so you get to see 2 weeks and 3 months for him. But he also had posts placed, and I think even early after surgery, you can see there's some symmetry to his ears, but clearly he's still swollen in this picture. And this little guy's also on the panel. I wanted to give you a pre-introduction to some of the little guys that you're going to meet, and they'll be able to talk to you. The future is exciting. We're not here yet, but there's a lot of active research going on. And so I plan to keep very much at the forefront of learning when these things become available to our patients. They're not there yet. It's interesting because it looks an awful lot like a Medpor implant, and it is an implant. It's a scaffold, and they need that scaffold to seed with stem cells, in this case abdominal fat, or they can make molds and inject cartilage, and they can create these things, but we're not there yet because when they did this with just cartilage and tried to make this ear, it didn't hold form, and it doesn't have any skin. And so they had to put a wire coil in there to make it bendable, and that's kind of what they're demonstrating. So it's exciting, but it's going to be, I think, many years out. So the last bit is just an advice slide. So everybody has a different opinion. You just have to know we all passionately believe in what we do, and we have our own reasons for that, and you guys just have to decide what feels right for your own selves or your children. There is no right answer. There's choices, and the key for my perspective is you just have to do your research and find a specialized surgeon, because this is rare. And it's absolutely your right to ask these questions. How many Microtia surgeries have you done? Some people maybe just do them on adults, so you can even say how many pediatric reconstructions have you done. I want to see before and after photos showing both ears so I can see how close they compare. If you only show me the one and you only show me one angle, it's hard to know. Right, oh, whoops. Okay, there's Courtney. First time she saw her ear. Do you remember that day? Yeah.
You waited a very long time. Oh my God, you're gonna make me cry.
I wasn't ready for that.
It's big.
This is the reason I love my job. I'll show you 2 more slides.
Yeah! Yeah!
Dave, Mikey said it's a grandpa ear.
No, it's not. You like your ear?
It's like this one and to that.
There you go.
Bada bing, bada boom.
All right, last slide.
Thanks.
You recognize that lady?
Looks good. Swollen, red, purple, just the way it's supposed to look.
You got a job out of that, babe.
It actually looks just like the picture that I gave you. You have a big ear. Probably too swollen. You want to see your ear? Just don't touch it. What do you think? You see a big ear? Yeah. Is that crazy? Yeah, I know.
I got big hair now!
So, bilateral patient looking at his ear for the first time. That kid is so cute. But all my kids are cute. We here at this conference, I think all believe we have the greatest jobs in the world, each and every one of us, and it's an honor to care for your children.